Thank you for joining us at this symposium, and thank you to the IAGG committee for granting us this opportunity to share our working group's investigations on exercise in polio survivors. My name is Michael Jackson. I am the clinical health educator for Polio Australia, and I manage and deliver its government-funded clinical education program. My background is in education and physiotherapy, and they serve as the foundation for my role educating health professionals Australia-wide on late effects of polio. So first, some background information on our topic for this symposium. Decades after acute polio infection, there are new or increased impairments that may develop in those polio survivors. A cluster of symptoms broadly referred to as late effects of polio, or LEOP, and they usually include muscular weakness, peripheral and central fatigue, pain at rest or during activities, sleep difficulty, breathing and swallowing difficulties, cold intolerance. And so clinicians face challenges advising polio survivors on exercise. Namely, they want to avoid increasing symptoms while trying to stabilize function and participation. Many exercise-oriented clinicians are unaware of the risks and constraints associated with exercise when performed by polio survivors. Additionally, polio survivors often have a fear of worsening their late effects of polio condition by engaging in exercise. And this can disengage them from participating in exercise, resulting in a higher risk and prevalence of comorbidities. Now, post-polio conditions are chronic and progressive, and as with some other neuromuscular conditions, the prescription and management of exercise has not been completely investigated. In order to improve both clinicians' and polio survivors' confidence in exercise, our working group is pursuing clinical trials and is developing a consensus statement on exercise for those with late effects of polio. This is based on recent work, which is a systematic review and meta-analysis evaluating cardiovascular fitness and strengthening interventions for polio survivors. And that was published last year, 2021, in the Journal of Rehabilitation Medicine. Our working group communicates with clinicians and researchers from New Zealand and Europe, and we welcome input and interest from other late effects of polio stakeholders. This symposium has 3 Australian speakers from our working group. Each will present for about 15 minutes from different clinical perspectives of exercise in those with late effects of polio. First will be Dr. Nigel Quadros on the medical considerations of late effects of polio. Dr. Tim Laflian is second on the FIT-BP principle for exercise prescription and how this relates to late effects of polio. And third will be Mr. Michael Jackson, myself, on the clinical implementation of exercise. I'd now like to introduce Dr. Nigel Quadros. Nigel Quadros is a rehabilitation medicine physician working in Central Adelaide Health Network and several private rehabilitation hospitals in South Australia. He is the only rehabilitation physician in South Australia that conducts a weekly medical clinic for patients with late effects of polio. Dr. Quadros has been treating aging polio survivors in South Australia since 2004, and is on the Clinical Advisory Committee for Polio Australia. He has been actively involved in educating medical professionals about late effects of polio, and with talks at general practices, and as well as writing articles on late effects of polio with myself. Through his affiliation with the University of Adelaide as Senior Clinical Lecturer, he has been involved in a research project looking at the prevalence of sarcopenia in polio survivors, and is looking at implementing appropriate exercises to reduce the progression of this condition in aging polio survivors. Dr. Quadros.
Ladies and gentlemen, thank you for joining this session, Exercise Prescription and Monitoring Those with Late Effects of Polio. I'm Dr. Nigel Quadros, as Michael Jackson has just introduced me, a rehabilitation physician who works in Adelaide, the capital of South Australia, with a population of 1.3 million, and we have approximately 300 aging polio survivors. In order to implement appropriate exercise interventions for polio survivors, we need to have an understanding of the acute infection, symptoms related to late effects of polio, impact of late effects of polio on the aging polio survivor, as well as impact of late effects of polio on medical comorbidities associated with aging. So if you look at the poliovirus, it's an RNA single-stranded virus that predominantly enters the human host via the oropharynx and exits via the feces. And transmission is really orofecal contamination, usually contaminated water. The virus then enters a cervical and mesenteric lymph nodes and then produces a transient viremia. And in most cases, this produces a flu-like or myalgic type symptom, and patients usually recover without any residual deficits. However, in certain circumstances, the virus can penetrate the blood-brain barrier, in which case it can infect the spinal cord as well as the brain. In the spinal cord, it has a predilection for the anterior horn motor neurons, which then lead to paralysis of skeletal muscles, predominantly in the lower limbs, as well as in the thoracic spine, and also in the shoulder and in the upper limb. In the brain, involving the cerebellum and brainstem, usually it's called bulbar poliomyelitis, and it can affect the thalamus basal ganglia, the hypothalamus as well, and the cerebellum, all of which affects things like temperature regulation, balance, sleep-wake cycles, etc. Now, after the poliovirus has infected a host, about 72% of people don't have any symptoms, a very minor illness, about 24%, and a few develop asymptomatic aseptic meningitis. But paralytic poliomyelitis only occurs in about 0.1 to 0.5%. And of those, majority, 79%, are the spinal polio, and 19% are the what we call bulbospinal polio. Now, with the polio eradication that began in 1988, you can see that at that time, a large proportion of the world has polio as an epidemic. However, by 2020, the two main countries that polio remains wild type is Afghanistan and Pakistan. In Australia, we had a large polio epidemic between 1938 and 1956. Vaccination began in 1956, and there was a dramatic drop in polio cases since the oral vaccine was introduced. And Australia was declared free of polio by the year 2000. We did have one sporadic case in 2007 when a student returned from Pakistan. Approximately 40,000 cases of polio were reported during the 1930s to 1960s, and most of those who are surviving now are in their 7th decade or later decades in life. When you look at late effects of polio, it really includes 3 categories of symptoms. Symptoms that are directly attributed to the poliovirus causing damage, and this results in residual weakness, musculoskeletal imbalance, growth retardation, skeletal deformity of affected limbs, and also respiratory problems. Post-polio syndrome is a symptom believed to be related to the body's failure to maintain the level of recovery achieved after polio infection. It has specific diagnostic criteria, which I shall outline shortly. And then there are symptoms related to secondary trauma, and that's due to the musculoskeletal imbalance or structural changes that occur. These people are more prone to compressive neuropathy, such as carpal tunnel syndrome, as well as degenerative arthritis of the joints, tendinitis, and bursitis. The diagnostic criteria for post-polio syndrome involves having a history of paralytic poliomyelitis with evidence of loss of motor neurons. Also, there should be a period of partial or complete functional recovery after the acute poliomyelitis, followed by a period of stable neuromuscular function. Then there is a gradual onset of progressive and persistent new muscle weakness, abnormal muscle fatigability, muscle and joint pain, and sometimes the onset may follow things like trauma, surgery, or a period of inactivity or deconditioning. and symptoms must persist for greater than 1 year. But the important thing is that it is post-polio syndrome if there are exclusion of alternative neuromuscular, medical, orthopedic problems, which can also cause these symptoms. Challenges that are faced by the aging polio survivor that may influence involvement in exercise interventions are twofold. First of all, comorbidities that exist due to the general aging process, and secondly, the late effects of polio. When we look at exercise interventions, may help to manage some of the medical comorbidities associated with aging. And polio survivors have an increased propensity to develop cardiovascular disease, particularly ischemic heart disease, dyslipidemia, hypertension. And this is related to sedentary lifestyle, perhaps inactivity, weight gain. Respiratory diseases are also common, such as sleep apnea, COPD, asthma related to respiratory muscle abnormalities. Again, exercise interventions such as aerobic exercises have been shown to reduce problems with dyslipidemia by increasing high-density lipoprotein. Blood pressure reduction is noted with aerobic exercise, which helps hypertension, as well as strengthening skeletal muscles, particularly the respiratory, inspiratory muscles can help with conditions such as COPD. Bone disorders, such as most commonly osteoporosis and osteopenia, are very common in polio survivors, and particularly you get asymmetrical osteoporosis involving the polio-affected limb. This leads to an increased propensity for falls, fractures as well. Again, exercises that can be implemented for these conditions include weight-bearing exercises and resistance training, as well as balance training to prevent falls and fractures. Diabetes mellitus is also more common in this cohort, and again, regular exercises can improve insulin sensitivity. Therefore, when we are designing any exercise prescription for these particular patients, they need to be screened for diabetes, hyperlipidemia, hypothyroidism, hypertension, osteoporosis, and always a lung function study is recommended. The other most important thing to consider is that we need to understand the feelings of the person as they are going through late effects of polio, which is, as this is important when we are developing interventions for exercises. Some of the common feelings these patients have is due to the new weakness and fatigue. They fear that there's a recurrence of the polio. They're confused about the symptoms. Is this polio or is it just natural aging? And also a lot of them are now reluctant to cut back on activities that they were normally able to do just a few months or even years prior. And they find it difficult coping with their new disability or impairments. So it's important for clinicians to be able to understand their grief, sit and listen to them and talk to them. In this way, work out strategies to relieve some of their anxieties and therefore be able to design exercise interventions which are beneficial to them. Now, the common symptoms seen in late effects of polio, and this was a survey done by the Polio Society of Australia on 1,300 patients from the different states in Australia. And the most common symptoms that patients presented were with fatigue, weakness, pain, breathing problems, and sleeping disorders. Fatigue related to late effects of polio usually occurs later in the day, and it can be classified into two types. Generalized fatigue that occurs with minimal exertion, and patients often describe it as an overwhelming exhaustion with the flu-like aching. Muscle fatigue is described as a heavy sensation that occurs often after exertion and resolves after a period of rest. Now, there are multiple factors that contribute to fatigue in late effects of polio, and clinicians need to be aware of these and particularly assess and manage them appropriately. There's obviously the psychological factors. There's lifestyle things such as sedentary lifestyle, poor nutrition, weight gain. But the most important thing are some of the medical conditions that we need to exclude, such as some infections, metabolic disorders, hematological disorders such as anemias, lymphomas, leukemias, also renal and liver disease, and rheumatic disease or rheumatological disorders such as polymyalgia rheumatica are quite common and can present with fatigue, which can also compound the late effects of polio. Sleep disorders are also very common, particularly sleep apnea, and this needs to be investigated in patients because this as well causes increased fatigue, particularly daytime. And for clinicians, the other most important thing is medications. We often use medications such as the statins, antidepressants, opioids, beta blockers, gabapentinoids, and tricyclic antidepressants to control pain and other medical comorbidities. These again need to be carefully monitored as they can also contribute to fatigue in these particular patients. Now, pain is usually muscle and joint pain, and this can be divided into two types: biomechanical pain, which is the most common form of pain, and this is usually a degenerative joint disease due to nerve compression syndromes and muscle weakness causing excessive pressure on the joints. And then there is the muscle overuse pain, which is occurs in muscles that are normally unaffected or mildly affected by polio, but need to compensate for the weakened polio muscles. But again, we need to look at some orthopedic conditions such as myofascial pain and fibromyalgia, which can also contribute to pain. Exercise interventions, together with strategies outlined below, can help manage pain associated with late effects of polio. And some of the non-pharmacological therapies may include lifestyle changes, massage therapy, heat and ice, using braces and assisted devices to protect joints, as well as weight loss, biofeedback counseling. And then pharmacological involves a variety of drugs, including non-steroidal, anticonvulsant drugs, narcotics, cannabinoids in extreme rare circumstances, and then invasive approaches such as steroid injections, nerve blocks, occasionally intrathecal analgesia, and joint arthroplasty. With muscle weakness and fatigue, again, we can look at specific muscle training, resting, avoiding muscle overuse, weight reduction, and learning how to do pacing activities. So when we look at managing patients, the principles of managing them with late effects of polio and designing appropriate exercise interventions, the most important thing to explain to the patients is that there are no medications currently available that have proven to reverse muscle atrophy, improve neuromuscular strength, or relieve neuromuscular fatigue related to late effects of polio. However, we can stabilize these symptoms and effectively manage these to improve or enhance their quality of life. And this involves a multidisciplinary approach, which involves a number of people, including rehabilitation physicians, primary care physicians, and number of allied health professionals working together to understand the polio patient and design together a specific exercise program and interventions that will benefit the polio survivor. Thank you for listening.
Thank you, Dr. Quadros. Our second speaker is Dr. Tim Lathlin. Dr. Lathlin is a postdoctoral research fellow at the South Australian Health and Medical Research Institute in conjunction with the CSIRO, the Northern Adelaide Local Health Network, and the University of Adelaide. Dr. Lathlin's research focuses on the benefits of exercise in helping to manage the risk factors for neurological, musculoskeletal, and cardiovascular health conditions. He has been a member of Exercise and Sport Science Australia for over 10 years as an accredited exercise scientist and accredited exercise physiologist. Clinically, Dr. Lathlin has supported polio survivors in the private and community healthcare sectors, working directly with medical practitioners through Medicare and supporting consumers through the NDIS. After being invited to several post-polio syndrome conferences, Dr. Lathlin has maintained an active interest in post-polio syndrome as an expert of exercise-based interventions for this population. Dr. Lathlin was the senior and last author and lead researcher on the recently published Effects of muscle strengthening and cardiovascular fitness activities for poliomyelitis survivors, a systematic review and a meta-analysis. Dr. Latlian.
Thank you very much for the introduction, and thank you, Dr. Quadros, for the first session looking at exercise prescription in polio survivors, those with the late effects of polio. I will be talking about exercise prescription and the monitoring for those with the late effects of polio using the FIT-VP principle. This presentation is in collaboration with the University of Adelaide and in conjunction with my employer, the South Australian Health and Medical Research Institute here in Adelaide, in the Clinical Health and Research Precinct, North Terrace in the City of Adelaide. The FIT-VP principle. So what is it? So the principles of exercise prescription help guide practitioners in the development of individually tailored exercise prescription, generally focused for apparently healthy adults whose goal is to improve fitness and health. Some individuals may not respond to this, and there is individual variability in the magnitude of the response. So the FIT-VP principle stands for frequency, so how often is the exercise prescribed or carried out, intensity, how hard, time, the duration, type, the mode, volume, which is the amount of exercise, and progression or the advancement of the exercise over a period of time. We look at older adults. The general guidelines are for aerobic, resistance, and flexibility activities, and these are categorized according to the FIT-VP principle. So in frequency, intensity, time, and type, and also volume and progression. So for example, aerobic exercise should be carried out for 5 or more days per week of moderate intensity, or 3 to 5 days per week of vigorous intensity. And this should be any activity that does not impose excessive orthopedic stress. So for example, for the post-polio or polio survivor population, aquatic, water-based or non-weight bearing activities are recommended. In conjunction with this, resistance or strength exercise is recommended, and this can be a percentage of 1 repetition maximum. So for example, starting with light intensity and then progressing to moderate or vigorous intensity, that is 60 to 80% 1 repetition maximum. So these are the guidelines for older adults, which is set out by the American College of Sports Medicine. For older adults at a risk of falls, such with those with neurological conditions, so that polio survivors are an example of this, neuromotor exercise is recommended, and this is recommended for 2 to 3 days per week. For example, balance, agility, and proprioception activities, starting with 2-legged activities going to 1-legged, so progressively making it difficult for the postures, and reducing the base of support, transitioning from static to dynamic movements, for example, doing a tandem walk or incorporating turns as part of the activities. And this can be home-based or under the supervision of an exercise practitioner. So this is for those who may be at risk of falls, and the polio survivor population certainly sits within that. FIT-VP principle, what is it not? So it may not apply in certain cases. So that is those who have various challenges to their health status, physical ability, or age, and therefore there should be accommodations made for individuals with clinical conditions. That is, special considerations and not a one-size-fits-all. When we look at neurological conditions, there is an example in terms of multiple sclerosis, and Exercise and Sport Science Australia have a recent position statement for those with mild to moderate multiple sclerosis. So in people with multiple sclerosis, they have reduced muscle strength, they have poor aerobic capacity, and they have impaired mobility. The benefits are due to both combined activities, so aerobic-based activities and resistance training, 2 to 3 days per week of moderate intensity. And this can improve strength, cardiorespiratory fitness, balance, fatigue, functional capacity, mobility, and overall quality of life, particularly for those with mild to moderate multiple sclerosis. Saying this, there are a range of exercise-associated complications, and these include fatigue and health sensitivity that need to be taken into account when prescribing exercise to this population. Currently, no guidelines exist regarding the optimal exercise prescription for polio survivors. The nature of the late effects of polio. So as Dr. Quadros outlined in the initial presentation of this symposium, looking at the medical aspects, in 1938, Australia recorded its highest incidence of paralytic polio. From 1961 to 62, that was Australia's last polio epidemic. And this coincided with the introduction of various vaccines. In the 1970s, many polio survivors began to report new problems. And 1972 was Australia's last case of wild polio virus. For 2016 and beyond, in Australia, there are an estimated 400,000 polio survivors. This is an estimate, and further work needs to be done in improving the accuracy and the precision of this estimate. And there's support services for the survivors of polio for up to 90 years following the last case of polio in Australia. So therefore, the legacy of polio certainly lives on. So clinicians face challenges advising polio survivors on the optimal levels of exercise whilst avoiding compounding pain and fatigue, so not increasing adverse effects. The context, the late effects of polio is chronic and progressive. Weakness can occur further to the paralysis associated with the condition and the initial virus. There can be pervasive fatigue, so high levels of fatigue, and there are mixed opinions in the literature on the optimal management of polio survivors, with exercise included as a part of this. Barriers include the societal impressions of polio being a condition that was prevalent many years ago, the polio survivors' fear of further loss and aggravating their symptoms, and uneducated medical and healthcare professionals. Many of today's medical and health professionals have not been educated in terms of polio and the late effects of polio. So what did we do? We did a recent systematic review and meta-analysis. We had this published in the Journal of Rehabilitation Medicine, where we looked at the effects of muscle strengthening and cardiorespiratory fitness activities for polio survivors. We carried out a search across several databases, and then we carried out both a qualitative appraisal and a meta-analysis of 21 studies. We used the International Classification of Function as the framework for our analysis and for setting out our methods. And we divided this in terms of domains. So the body function domain, as well as the activity and participation domain, and then further divided body function into muscular, cardiovascular, and mental and sensory for the adverse effects. What were our findings? So looking at the effect of exercise on the body function domain, including both lower and non-lower limb function, there was a moderate improvement due to aerobic fitness activities. And there were small improvements in both mixed aerobic and resistance training and strengthening or resistance training activities. When we look at the cardiovascular component, this is heart rate, blood pressure, or aerobic capacity, we found that there was a small to moderate improvement due to aerobic fitness activities. When we looked at the effect of exercise on the mental and sensory component, so self-report of pain, fatigue, and other aspects, we found that there was a moderate to large improvement due to aerobic activities and also strengthening activities. And when we looked at activity and participation, this is self-report of health status and quality of life and various measures such as the timed up and go and the 10-minute walk test. Exercise interventions produced a small positive effect, mixed interventions a small positive effect, and aerobic and strengthening interventions were not significant. So there was a range of findings across the different interventions. We did find that all data sets were relatively homogeneous, so there was limited variation across these data sets. We then carried out the recommendations according to the certainty of evidence using the grade recommendations. And we found that activity and participation domain, looking at randomized controlled trials only, there was a high certainty of evidence. And for the body function, mental and sensory, there was a moderate level of evidence for randomized controlled trials alone. All other study designs across the other domains were very low certainty of evidence. And this was mostly due to the risk of bias, so confounding, no measure of random variability, limited loss to follow-up, substantial heterogeneity, and differences in the criteria for diagnosing the diagnosis of post-polio, as well as a wide confidence interval indicating the error. So what we found overall is that exercise interventions benefit this population when individually prescribed. The benefits are that there are a low number of adverse events. We can avoid both disuse and overuse weakness associated with in polio survivors, and we can reduce other health risks. So we can reduce the cardiovascular burden or risk associated with aging and further disability. Guidelines, these provide, our research found a number of different findings that can help with guidelines for improving the knowledge of clinicians and researchers. We recommend that clinicians prescribe conservatively, respect the adverse events such as pain and fatigue, and monitor and modify appropriately. So how does this research fit within the overall scheme of what we are aiming to do within the polio survivor population? So if we use the RE-AIM framework, which has been applied to a range of different areas and has been in use in public health for the last 20 years, we're aiming to reach the polio survivor population within Australia. We're aiming to improve the accuracy and the precision of what we know, the number of polio survivors. We're aiming to improve the effectiveness of the various treatment and therapies, particularly exercise-based interventions. And we're aiming to help drive the uptake of those engaging in these interventions. We aim to implement using evidence and experience, and then maintaining positive public health impacts in this population. So what's next? As Dr. Quadros outlined, there needs to be a paradigm shift to enable a biopsychosocial approach. We need to shift from seeking a cure or fix to optimizing rehabilitation and function. We need to shift from focusing on pain, fatigue, and weakness to a focus on function, less reliance on medications and more focus on multimodal therapy, and enabling active self-management rather than treating the patient, that is passive therapy. So what's next? Integrating digital health solutions. So we're looking at a range of telehealth and other digital health interventions with bespoke exercise-based platforms. So there's some great examples coming out of the Netherlands with the BFIT program and a range of implications and implementation of that program. So what's at stake? If we do not apply further research in this area and look at novel ways of progressing it, we can have just the status quo of level of care, so maintaining the current level. There's the disability with aging, and what's within reach, as stated here, a paradigm shift, optimizing function and self-management, and optimizing the quality of life of polio survivors. So thank you very much for listening to my presentation. I'm more than happy to take any questions now or take any questions at the end of the symposium in conjunction with Dr. Quadros and Michael Jackson, who will now talk. So thank you very much. Here are some references that you may be interested in, specifically in the Netherlands and some of the work that's done recently. So thanks very much for listening to my talk. Happy to take any questions.
Thank you, Dr. Latlian. The third speaker is myself, Mr. Michael Jackson. In addition to what I mentioned earlier in the introduction, I am a co-author with Dr. Latlian on the paper Effects of Muscle Strengthening and Cardiovascular Fitness Activities. In 2021, I presented on this paper on exercise and late effects of polio at both the Australian Association of Gerontology Conference and the Rehabilitation Medicine Society of Australia and New Zealand virtual conference. Hello, my name is Michael Jackson. I am the Clinical Health Educator for Polio Australia. Polio Australia is the peak body that looks after the needs of polio survivors across Australia, and we've been operating since about 2008. I deliver a clinical health program across Australia where I go out and visit clinicians. My role today is to share aspects of clinical implementation with regard to exercise prescription with those with late effects of polio. Really what this section is going to cover is understanding fears and apprehension about exercise with this population, looking at the body system's capacity we need to understand, and then also looking at interventional risks with exercise, particularly activity and exercise out of those risks. So the consensus statement we've have as a part of our abstract and as a kind of our ultimate goal does serve clinicians and polio survivors. In the 2004 study, Reckland et al. Concluded that physically inactive patients are at a higher risk for late polio-related symptoms, and an active lifestyle should be recommended for patients with polio sequelae. Now, in particular, we need to offset that sedentary tendency which brings with it the risks of cardiovascular disease and obesity. With polio survivors exercising, particularly those with a history of paralysis, we need to address and reduce what looks like both health anxiety and fear avoidance, because exercise in this population can be perceived as a risk or a threat to their ability to function. And excess strain during exercise can increase their pain experiences. So motivation for exercise may be low. And this was highlighted by Baker et al. In 2016 when looking at exercise and cognitive behavior therapy. But how can we improve polio survivor confidence? Well, we need to initially think about the initial advice that many of them received in the mid-80s and up into the mid-90s, when the advice was very protective and conservative in terms of preserving the function that they had. And then the research started to emerge on exercise and tolerance. And from that point on, we kind of realized that, look, exercise was safe under certain tenets or constraints. And certainly status quo approaches should be avoided to help polio survivor confidence. That survivor needs to own their individualized program to really appreciate that it is strictly developed for them, and that the more strictly they adhere to the parameters that that fits VP parameters that Tim was just talking about, the more successful and less frustrating exercise will be for them. And then they also can increase confidence by seeking and utilizing late effects of polio-informed clinicians. So clinician confidence, that is also a key factor here, because simply being aware of the condition, that it exists, does build clinician confidence, and that's part of my role in Australia. Detecting late effects of polio, so having screening mechanisms in place and things like having it listed on intake forms in each of the clinics helps that awareness. Of course, understanding the condition, and then the interventional risks, being very aware of those related to exercise. And then that consensus statement really is going to be that guidance from the exercise research. And we know that there is certainly some gaps in that research and work to be done, but at this point in time, a consensus statement would better serve clinicians and polio survivors. A concept that I really emphasize in my education of clinicians is related to capacity limitations with polio survivors. And so I'm going to go through that, and that's related to the gear stick you see in the picture here. On the left-hand side, the top part of that is really those factors, neuromuscular factors, that determine physical limitations, capacity limitations. And down the bottom are other body systems that can or should be considered when thinking about body capacity related to exercise. So with our gear stick, if we drive a car, we can use all of the gears. Short distance, local trips, we would use the lower gears. But if we were going to go interstate or across vast distances, we'd want to have that fourth and fifth gear. And when someone has had polio, we can think about it as they've lost that fifth gear, that damage from acute polio that's been with them through their stable disability phase. And then there's clinically undetected damage. And that's like having a fourth gear that works, you know it's there, but it doesn't always hold, it doesn't always engage. It's a bit of a problem. And so a survivor may not be able to articulate that experience, but if we relate this to them and we think about this as clinicians, it can make it easier for both sides to communicate about their capacity. Late effects of polio comes on after that period of stable disability, and we have this threat to function. We have the threat here to how well are we going to be able to use our vehicle if we've lost fourth, fifth, and third gears, and we're only left with a capacity of 1 to 2. So that threat to function is very real, and we need to understand that what we see in the survivor, we need to link to what we hear them saying about their capacity to reduce their frustrations in healthcare. So this is useful for clinicians to use to understand, but also they can share this idea about capacity with their clients. So when it comes to interventional risks, we've identified, and I teach to 4 risk areas in Australia to allied health therapists and nursing and medical staff. And those risk areas are activity and exercise, fall risk reduction, medications, and anesthesia and surgery. And you can see there's kind of an interaction of different risks apply more to different disciplines in the multidisciplinary team. For exercise intervention, we're really going to focus on these 2, activity and exercise. We're going to split those up. Really, that's about identifying and respecting those capacities that we just talked about and the breaching of thresholds of those capacities, in practical exercise prescription. And then looking at fall risk reduction, because a fall can really disrupt body systems and function and interrupt the health trajectory of a polio survivor. The other 2 are obviously important, but we're not going to focus on them. So first, activity. Now, activity is probably seen more as an occupational therapy area of intervention, but in reality, if we look at this slide, we can see there's a lot of concepts here that can be taught and used through education by the health team. That system capacities, we need to realize that symptoms can be exacerbated with excess strain, that breaching that threshold of the capacity. And those symptoms, fatigue, weakness, pain, are the main ones, and they can fluctuate in response to strain. And so what we get is this roller coaster experience for polio survivors, and that can be over days, can be over weeks. It's very individual and variable. And if we can smooth out that roller coaster by not breaching capacity, then we find that quality of life and consistency in predicting activity and exercise is much more reasonable. With the onset or the progression of late effects of polio, we need to reassess that capacity, because that capacity may be changing across a number of different systems. And then we need to think about, what are our strategies going to be oriented to? And it's going to be selective effort and then disciplined rest. So it may be counterintuitive to think, right, if I'm experiencing fatigue and weakness and pain, why would I bother adding in exercise? And that is kind of that old protective view, but we need to really think about what we do know in terms of the research that has been done, and that the use and effort of exercise is actually not harmful when those tenets are applied. So what are those tenets? First of all, it's important to note that on the left-hand side of this slide, that the whole client context is important before we think about providing exercise. A thorough assessment, obviously, and evaluation is done, really understanding that functional status, activity tolerance, participation, and then reviewing the aids and assisted equipment used, particularly those with a history of paralysis that affected function. Tim had mentioned the meta-analysis and systematic review that we had done and published last year, where we found it was beneficial and safe to exercise across numerous studies. And these are those tenets. Really, it's that prescribing and monitoring exercise and having well-informed clinicians provide that prescription. Looking at non-neuromuscular systems. So cold intolerance is one other system and problem that survivors have with exercise. And if you think about getting in and out of a pool to exercise, which is often used by polio survivors in Australia, getting in and out is obviously a health risk in terms of falling, but also in terms of getting cold and not being able to re-warm the body in the hours after that exercise. And so that can exacerbate pain and fatigue as well. And then also ventilation. We may have a survivor who is a 4+ or a 5 on their limb musculature, and yet they can't tolerate exercise. It may come down to they had hemidiaphragm as a child with their polio, and so their ventilation limits their exercise. The team needs to be sensitive and responsive. They need to be the ones asking, okay, is this tolerated? Is this too much? What are your symptoms? How are they changing? And the client needs to be readily sharing that information. Obviously, choosing mode of exercise is very important. We're going to talk about the risks shortly. And remembering that the FIT VP that Tim had outlined is muscle group specific. We don't apply 3 sets of 10 of an exercise across the body. We need to think, right, this area can tolerate this much, this limb can tolerate this much. We might exclude a limb from exercise. So that's the bigger overview without getting into the nitty-gritty of prescriptions themselves. For risk reduction, this is a slide that I present to our clinicians across the country. Really, it just summarizes the major studies that asked about 1 or more serious fall per year in polio survivor populations. And you can see listed down on the left-hand side the countries. So it just shows, yes, look, this is a topic that's been investigated across many countries. The years listed here, the oldest study here is 2010. So the research on falls is reasonably young. And then we get good numbers, obviously, but in the orange and red, we can see that fall rate is quite high, above 50% across studies. And the average, the prevalence of falls in the elderly above 60 years old in Australia is about 30%. And we did a study of, we asked a survey of 180 of our polio survivors, and about 58% of those reported 1 or more serious falls per year. So around the level of the Swedish study here. And then in terms of factors identified, you can see there's quite a number of different factors there. So we just need to remember fall risk reduction, as well as exercise prescription, is very individualized because of the variability in that individual themselves and how they present and what their dysfunctions are. So this is a high risk group. So in summary, related to exercise and fall risk reduction, there is that higher fall rate and higher osteoporosis rate. Now, it was Mohammed in 2009 with his colleagues, and they looked at osteoporosis and found that in polio survivors, 56% had osteoporosis, and 40% in that group of 50 had osteopenia. So they're a high risk for fracture if they fall. So we talked about multifactorial, individualized interventions, but also remembering that anything you do in a fall risk program can be exercising, and so it needs to respect capacity as well. And then exercise prescriptions should minimize risk scenarios. Some of these I'd already talked about, aquatic hydrotherapy, but also it's important to remember that recovery after efforts need to be monitored, that their mobility doesn't change after they perform exercise. Because if that changes, then that may put them at risk for falls. So in summary, common factor here is education, which can be shared by all types of clinicians. Those nuances that would really add great detail to a position statement. We don't have all the answers for prescription of exercise, but we do know that a consensus statement would really improve the confidence and the consistency of the care of polio survivors. So thanks for this opportunity. I look forward to your questions. Many thanks to our speakers for their expertise and insights on this topic. We now have some time remaining where we are able to answer any questions that you may have on this topic or on our work.